Assalamu alaikum. I hope you're all doing fine. I am Dr. Muhammad Ali Rabbani, and today we are going to discuss the pectoral girdle and its muscles. I hope so. This lecture will be very interesting for you, and we will look into what are these muscles, how do they function, why they're important, and this is going to be a useful lecture whether you are into bodybuilding, anatomy, or are just curious about your body. So, pectoral girdle. So pectoral girdle is the part that connects your upper limb muscles to the skeleton of the axial skeleton. It consists of the scapula bone that is on the back of your shoulder and the clavicle bone in the front. And as you can see, the scapula does not have any bony connection with the axial skeleton except this joint. This is the this is the acromion process, this one, acromioclavicular joint, and clavicle in turn it's attached to the rest axial skeleton or sternum through this joint, sternoclavicular joint. So this is the only bony connection between the pectoral girdle and the axial skeleton. As you can see, it will not provide you with much stability that will be required. So this is enhanced by muscles, a lot of muscles present in the front, a lot of muscles present in the back, and all of these muscles, they capture and keep the pectoral girdle in place, also allow for a wide range of motions. As you can well imagine, in the absence of bony connections, the scapula is much more free to be mobile, so that is available. Muscles of the pectoral girdle. We will talk about the muscles that are attached to the pectoral girdle. They can be broadly divided as axio-appendicular muscles that connect the pectoral girdle, scapula and clavicle to the trunk, axial skeleton, and scapulohumeral muscles that connect pectoral girdle, scapula and clavicle to the upper limb. Let's talk about the axio-appendicular muscles. These muscles, they join the trunk or axial skeleton to the pectoral girdle. They can join the maybe directly joining them, meaning direct connection between the pectoral girdle and axial skeleton. And here are the muscles that are involved. So there is pectoralis minor muscle, as you can see, between ribs and the coracoid process of scapula. Subclavius muscle between the first rib and the clavicle, rhomboidus minor and rhomboidus major muscles between the scapula and the spine of vertebra, and levator scapulae muscles between the transverse process of cervical spine, transverse process of cervical vertebra and the scapula. Serratus anterior, this large muscles covering the sides of the ribs, and last but not the least, trapezius. So trapezius I will show you here. So these are the muscles. Pec minor, beneath this muscle pec minor, it is hidden by pec major in this picture. This is a picture from Natter. Subclavius again hidden. Rhomboidus major and minor on the back. These are rhomboidus minor, major and levator scapulae. Serratus anterior, latissimus dorsi, serratus anterior and trapezius. This large triangular muscle is trapezius. So these are the muscles that are, this is trapezius. They are directly connecting with the axial skeleton to the appendicular muscle, axial skeleton to the pectoral girdle. Then comes the two muscles that indirectly join the axial skeleton to the pectoral girdle, and these are pectoralis major muscle. You can see running between clavicle sternum and the humerus, and there is latissimus dorsi attaching to the lower back and through thoracolumbar fascia to the this pelvic girdle and getting attached to the humerus. Although they are not getting attached, both of these muscles are not getting attached to the pectoral girdle, meaning the clavicle and the scapula, but through their indirect connection, they are nonetheless providing support to it. So these are the axio-appendicular muscles. Pec minor, subclavius, rhomboides, levatoscapuli, serratus, anterior, and trapezius, providing direct connection between girdle and axial skeleton, and pec major and latissimus dorsi, providing indirect connection through humerus. Then comes the scapulohumeral muscles. As the name indicates, these muscle joins the scapula and to the humerus. So this will include this deltoid, the muscles forming the bulk of your shoulder, this subscapularis muscle, the muscle in front of the arm, on the front of the scapula. On the back there is supraspinatus muscle, then there is infraspinatus muscle, then there is teres minor and teres major muscles. We will go into the details of these shortly, and we have already discussed these muscles attachment in the respective lectures of scapula, clavicle and humerus. So these muscles, the subscapularis, supraspinatus, infraspinatus and teres minor, these muscles together are called rotator cuff muscles. So these are the muscles. I will not be discussing these lectures in these muscles in this particular lecture. Biceps and triceps, these can be also considered as scapulohumeral muscles because one head of each of these is attached to the scapula bone. So here are pictures from letters showing subscapularis, supraspinatus, infraspinatus and teres minor. And here teres major is shown. Before moving forward, I would like to discuss the concept of axis of movements and line of pull. As you have already discussed in the lectures of general anatomy, by the way, those are present on our website and on the YouTube channel. The movements are along three axes, like for a shoulder joint. Let's take this for an example. This here it provides flexion and extension. It's along the horizontal axis, flexion and extension. Along the anteroposterior axis, there is abduction and adduction, and along the vertical axis, this vertical axis, there is medial and lateral rotations. So whenever you find yourself thinking about what the function of this muscle will be against these axes in the joint, try to think of the position of the muscles with respect to these axes. For example, let's talk about horizontal axis. Horizontal axis was providing the space for flexion and extension. Any muscle that is running in front of the axis and pulling upwards will lead to flexion. The same will be true for elbow, the same will be true for wrist. The any muscle like the anterior compartment muscle running in front of the elbow on the way to the forearm, they will provide flexion of the elbow. Similarly, the muscles that are pulling upwards running back from the posterior aspect of this horizontal axis, that will provide extension, like the posterior aspect of deltoid in the shoulder region, like the triceps in the elbow region, like the extensor muscles on the wrist region, because all of these muscles are passing posterior to the horizontal axis. Then there is anteroposterior axis. You can it uh, it depends upon, it's a little uh, easy to visualize than to describe, but if we're pulling from upwards, any upward from the outer aspect of this anteroposterior axis, from the lateral aspect of this anteroposterior axis, this will lead to abduction. Any upward pull from the medial aspect of anteroposterior axis will lead to adduction. But please do be very careful regarding the line of pull that is in the opposite direction. Like if upward pull outside can lead to abduction, then downward pull outside can lead to adduction. If upward pull inside can lead to adduction, then downward pull from inside can lead to abduction. And last but not the least, there is vertical axis. This I have found that this movement does confuses the early students, because this movement we are not very clearly seeing as the body part moves. For example, when the humerus is rotated medially and laterally, the humerus does not leave its place. On the same point, it rotates along its long axis. Sometimes when we do that, my forearm is moving out. This movement of the forearm is considered as medial rotation, but that is not the case. It is the movement of, even if I put my arm straight, this inward rotation of this muscle of the bone along its long axis, this is the rotation. Medial rotation when the anterior surface go medially, and lateral rotation when the anterior surface go laterally. So any pull of muscle that pulls the anterior surface medially, this will lead to internal rotation, or any pull that pulls the lateral surface outwards, that both of these will provide internal rotations. Anything that pulls the anterior surface outwards laterally, or posterior surface inwards medially, so uh, these will provide lateral rotation. We will now start with our muscles, starting from the anterior axio-appendicular muscles, the muscles of the pectoral region, the muscles that are present on the front. We will not be demarcating between the direct or indirect. We will start with the pec major, we will go on to the pec minor, and then we will go to the back, cover those muscles. So let us start with anterior axio-appendicular muscles. First up is pectoralis major muscle. I will be using picture from Grant Settlers or Keith Elmore textbook, and the tables are from Keith Elmore textbook of gross anatomy. So pectoralis major, that is the huge triangular muscles that lies in front of your chest beneath the breast tissue. Bodybuilders, you know it well, and it runs from the clavicle and the sternum and to the all the way to the humerus. And it, as it does attaches, it folds upon itself, creating an anterior axillary wall in front of your armpit. Let us break down its origin. It has clavicular head that arises from this two-third of the clavicle, medial two-third, anterior surface of the medial two-third of the clavicle. Then there is sternocostal head. It originates from the front of the manubrium sterni. Here you can see it, and the body of the sternum. Also, it arises from the corresponding sixth costal cartilages, not exactly shown in this model here. Now the insertion. This muscle goes on to get inserted here. It goes on to, let me start with the origin. The origin has, there are two origin. The clavicular head, it arises from this part, the anterior surface of the medial two-third of the clavicle, and then there is sternocostal part. It arises from the anterior surface of the manubrium sterni and the body of sternum and corresponding upper six ribs. So it arises from here and it gets inserted into this part, that is the lateral lip of the bicipital groove or lateral lip of intertubercular sulcus. So this is the muscle. As you can see, this muscle is having a spiral arrangement, and you can see the fibers coming from up. Technically the insertion is bilaminar. um, this means that it is not as a single item. Here it is like this, there is a bilaminar insertion. The fibers that are having lower point of origin, they come out and insert here. As we continue on going up, the next fibers get progressively inserted down, and then the next fibers start getting attached to the anterior lamina. So here you can see that this particular arrangement leads to the spiraling nature of the pectoralis major insertion, as it's shown right here. Right here. So this is the spiral nature of the pec major that is shown right here. Let's talk about it. Its supply. This muscle, this muscle is supplied by arteries and nerves like all the other muscles, and the nerves that are majorly supplying these muscles are medial and lateral pectoral nerves from the medial and lateral cords of the brachial plexus. And as you can see, 1, 2, 3, 4, 5, it gets supplied from all the roots of the brachial plexus from C5 to T1. So this is the muscle, the only muscle, the one muscle that you can test to check all the root values of the brachial plexus. Talking about the arterial supply, the arterial supply is through a number of arteries. This is here you can see there is internal thoracic artery, also called internal mammary artery. Its perforating branches go to the front, and then there are various branches of axillary artery, including the superior thoracic artery. Then there is lateral thoracic artery. Then there is thoracoacromial artery, especially with its pectoral branch. So all of these different arteries, they get to supply the pec major. And pec major is a very powerful muscle. I will shortly go into its functions. By the way, you should also know that this is the muscle. Beneath it, you can make a pocket and you insert the prosthetic in case of breast implants beneath this. Now let us talk about its functions. It does, as the shoulder joint is a very mobile joint, this muscle plays its part in the movements across all three axes. Along the anteroposterior axis, there is adduction and abduction of the shoulder joint. So, to test this muscle, you ask the person to flex the shoulder joint and abduct it. Then, as you adduct it, you do remember that the muscle approaching from the front, from the front, and uh, it's approaching from the front and from the medial aspect. So when it is pulled, it pulls the arm in. So this is how this muscle helps in adduction. This muscle helps in adduction. Let me get it back. When the arm is abducted, you this is how, by the way, you test the muscle. You ask the person to abduct the shoulder, and then you adduct. You can ask adduct by this method, or you can just ask, let me put myself here. You can ask the person to put your hand up and get it in the middle. In both of the methods, the along anteroposterior axis, this is pulled forward, this is pulled inside. The second function, that is the flexion. As you can see, the flexion is having a long transverse axis, and this muscle is approaching from the origin to insertion from the anterior aspect. And so when it contracts, as you can see, this muscle is passing anterior to it. So when this muscle is contracted like this, it pulls forward. I know there are other muscles that are helping in overhead abduction, but at least for the most of the part, this is the flexion. Like when this muscle is highlighted, this is the movement that is made possible by pec major. And last but not the least, there is medial rotation or internal rotation, as this muscle is approaching from the medial aspect as attaching to the anterior surface. It pulls the anterior surface inwards, thus helping in internal rotation. So this muscle, we talked about the pec major being attached to the clavicle head, anterior surface of the medial 1/3, medial 2/3, sternocostal head attached to the anterior surface of body and manubrium, and six costal cartilages, and the aponeurosis of the muscles underneath it that will include external and oblique majorly. Getting attached to the lateral lip of the tubercular sulcus to bilaminar disc, being supplied by lateral and medial pectoral nerves through all the roots of the brachial plexus, and giving a function. It is helping in adduction, medial rotation, and flexion of the shoulder joint. Next, talking about its clinical syndrome. This is an embryological condition, Poland syndrome, that is chiefly recognized by the absence of pectoral muscles, majorly pec major muscles. As you can see, this is the surface landmark created by normal pec major. Normal pectoralis muscle, if this muscle is absent, you can see the difference in the placement of nipples and the bulge of the chest. Then comes the pectoralis minor muscle. As you can see in this model, this is the muscle that is present just underneath the pec major muscle, and when talking about its attachment, this is originating from rib number 3, 4 and 5 majorly. So this is the origin of pec minor muscle, the ribs, and it is getting inserted into this coracoid process. So you can see its insertion right here. This highlighted part, this is the insertion, and these parts, this are the 3 points of origin from the rib number 3, rib 4 and rib 5, and between them you will see the pec minor running. This muscle is supplied by both pec lateral and medial pectoral nerve, majorly by medial pectoral nerve, and similarly its arterial supply consists of majorly this thoracochromial artery and lateral thoracic artery. The function of these muscles majorly depends upon what part or which end of the muscle you are considering fixed. So for a fixed ribs, you can see this, if we consider that ribs are fixed and the scapula is free, so when this muscle contracts, this pulls the scapula forward. It is more evident when you see from the side. Like you can see when this muscle contracts, it pulls the scapula forward. So this is the protraction function, and when you put your arm out, and this last push that you get from the shoulder, that is through pec minor muscle. Secondly, as you can well deduce from the its position, when it contracts, it can pull the scapula down. It helps in depression of the scapula. One more function that I am not very well able to show in the model here is when scapula is fixed. For example, like when I put my hand on my hips or some help, now the scapula will not go down easily. And when pec minor is contracted, rather than pulling the scapula down, now the scapula is fixed. It will help in pulling the ribs up. It will help in pulling the ribs up. So these muscles act as an accessory muscles of inspiration when the scapula is fixed, and you will see a person who is breathing laboriously, putting his hands on the hips or some table or anything and taking deep breaths. So this is the function. So this is about pectoralis minor. Then comes the serratus anterior muscle. This muscle originates from the serrate eight ribs. As you can see from here all the way to rib number 8, it originates from here and get inserted on the medial aspect of the medial aspect of the anterior surface of scapula. So here is an isolated model of the origin and insertion of the serratus anterior. So here you can see it is arises from the lateral or outer aspects of the first 8 or 9 ribs, as you can see right here, and it goes back and get inserted here on the anterior aspect of medial border of scapula. It This is where it get inserted. So this is the origin and insertion. Here you can see this muscle, not very visible on the anterior views, but as you can see from the side, it is very prominent, running from the medial border of scapula all the way to 8 ribs. The first two slips you can see originate. First slip you can see originating from both the this first slip originating from both the first and second rib, and then each slip getting originating from the nerve of the rib of the same number. So the nerve supply, the major nerve supply that you have to memorize is this, the long thoracic nerve. This is a nerve that is originating from the roots of the brachial plexus. As you can see, it is arising from 3 roots of the brachial plexus, and then it comes down and runs on the surface on and the medial aspect of axilla, supplying it. This is the long thoracic nerve. Sometimes you may read it as the nerve to the serratus anterior. And one more thing to get it straight right here is that as it is present on the medial wall of axilla, this nerve is vulnerable to injury when there is surgery of the mammary gland or the breast tissue, especially when you are dissecting out the tail of the breast coming right here. And its supply is majorly from the branches of the axillary artery, and these will include the lateral thoracic artery and thoracochromial artery and some branches of the subscapular arteries too. So this is about the nerve supply, the origin insertion that brings us to its functions. Major function of this muscle is to pull the scapula forward into the ribs. As you can see, when this muscle is contracted, it pulls the scapula forward, so it is helping in protraction of the scapula. And it is helping in protraction of the scapula, and as you can see, as it contracts, not only it pulls the scapula forward, it helps rotate it too. So it helps rotate it in such a way that the upper end goes medially and the lower end goes outward. So due to this rotation, when there is this rotation, when the upper end goes medially here in this model, in this lower end it goes laterally. So through that, it as it rotates like this, it helps in overhead abduction. So when you are talking about the function, you will see it as getting it attached or getting it in close approximation to the ribs, and protraction and rotation helping in abduction. So these are its functions. So here is a picture with a summary, and you will see its origin. You have saw it origin from the eight ribs, insertion into the medial aspect of scapula, its function protraction and abduction, overhead abduction, its nerve supply from long thoracic nerve, and arterial supply from branches of axillary artery. When this muscle is paralyzed due to the injury of nerve, that may happen in the breast surgeries or mastectomies, then this person is not very well able to keep the scapula attached to the ribs. There is a forward pull is lost. So when a person is asked to put the hands on the surface of the wall and push, then the scapula of the affected side gets a little back. So this is called winging of scapula. This brings us to the small last muscle, that is the subclavius muscle. You saw in the clavicle, this muscle is attached to the subclavian groove on the inferior aspect of clavicle and attached to the first rib. So this is a horizontally running muscle, majorly helping in keeping the clavicle stable during the movement of girdle, and it anchors the clavicle and depresses it, and it is supplied by a nerve of the same name, that is nerve to the subclavius muscle. Moving on, one more thing I would like to discuss regarding pec minor. It's apart from its function, that is the depression, protraction, and sometimes the forceful inhalation. This muscle is very important as a surgical landmark for us. As you can see, it is crossing the neurovascular bundle passing beneath it, including the axillary artery, vein, and brachial plexus. So we define axillary artery and its parts based on it. The part that is before the muscle is first part of axillary artery. Then there is second part behind it. Then there is third part lateral to it. Similarly, there is the name of the lateral thoracic artery coming from the lateral aspect of pec minor, and then the lymph nodes, the axillary lymph nodes, that they are given levels based on that. The one that is before pec minor are first level 1, including humeral, subscapular, pectoral nodes. Then there is level 2 and level 3, depending on the nodes that are behind and beyond the pec minor muscle. So pec minor has a very important function as a landmark. So this was about the muscles of the anterior aspect of pectoral girdle, pec major, pec minor, subclavius, and serratus anterior. It's technically not most anteriorly but on the medial wall, but we discussed it. Now let us talk about the clavipectoral fascia. If you dissect out the pec major, beneath it you will see this fascia, the clavipectoral fascia, running from the clavicle above down and to the axilla here. And let me show you here the pictures from the atlas. So this is clavipectoral fascia. Above it is starting from the undersurface of the clavicle right here. Below it is being inserted on the fascia of the axilla. And the medial aspect it is attached to the ribs right here. And lateral aspect it is again going to the axilla and the muscles there. It encloses two muscles within it. Here there is subclavius muscle and here there is pec minor muscle. These two muscles are embedded within the clavipectoral fascia. So as you can see, the fascia, two-layered fascia goes, splits, covers the subclavius muscle, then goes, splits and covers the pec minor muscle. So here is the picture that is like this. If you cut it like this and then see from this side, then you will get this picture. From the skin superficial fascia, deep fascia, you saw pec major, and when you removed it, you saw this clavipectoral fascia. So it is split to enclose subclavius under clavicle. Then there is a constant part. Then it splits again to enclose pec minor. Then goes down, and then it is attached here to the fascia of the axillary foot. And that is why when you put your in abducted position, your axilla goes into the concave shape because this fascia pulls up the fascia of the axilla. So depending upon due to the parts, depending upon the placement of the pec minor, it is divided into two parts. Then there is a part that is above the pec minor, this part. So this whole part is called costocoracoid membrane. Why? Because here is the coracoid process, it is attached to here, and through here it is attaching here to the rib number 1, 2 and 3. So this is costo costocoracoid part, and its part that is just beneath and parallel to the subclavius muscle, this part is thickened, so this is called costocoracoid ligament. This is the costocoracoid ligament. And then there is come the part that is beneath the pec minor all the way to axilla. So this part is called suspensory ligament of axilla because the fascia of the axilla is suspended through this. You are very frequently asked question, which structures are piercing the clavipectoral fascia. There are two structures going inwards, two structures going outwards. The inward going structures, one is very clearly shown, is this blue colored cephalic vein carrying the blood of the superficial of arm to the inside, and one thing that is not shown here is the lymphatics from the to the going to the apical group of nodes. Basically lymphatics accompanying cephalic vein. Things coming out is this artery. This is the thoracoacromial artery with had its four branches, three shown in this picture. This pectoral, deltoid, and acromial, and these branches supply this pectoral region. And then there is this nerve that is the lateral pectoral nerve on the way to the pec major muscle. So these structures are shown right here too. There is thoracoacromial artery, cephalic vein, and this lateral pectoral nerve. By the way, you must keep in mind that pec major is always supplied by both lateral and medial pectoral nerve. Pec minor is majorly supplied by medial pectoral nerve, sometimes by both, but majorly by medial pectoral nerve. So on the way to pec major, medial pectoral nerve passes through both, through the pec minor muscle on the way to pec major, and the lateral pectoral nerve goes through clavipectoral fascia to the muscle. So this was all about the clavipectoral fascia. Now we will move on to the posterior axio-appendicular muscles, starting on trapezius and rhomboides and all these muscles. Let us start with the trapezius muscle. This is a very large muscle that is present on the back, and as you can see in this model, it together with its counterpart muscle on the opposite side, this make this trapezoid shape. That is why this is given the name of trapezius muscle. This is a very large muscle. We will see its extensive uh, attachments. So there are two muscles, and it attaches all the way from skull down to the ribs, down to the vertebra, all the way to thoracic vertebra. Let us isolate its origin and insertion. So let us start its origin from here. It is attached to the this ridge on the back of your head that you can palpate. This is the superior knuckle line, and then there is a prominence in the midline here. This is the external occipital protuberance. From here to here, the origin is not shown, as this origin is not bony. It is attached to a ligament. I will show in the picture, superior knuckle ligament. Then it is attached to all the 12 thoracic vertebra, and it is attached to the tips of the spines. As you can see, its attachment here on the tip of the spine of all the thoracic vertebra. Then from this vast origin, it gets inserted into scapula and clavicle. On the scapula, it is attached to the root of spine of scapula. It is attached to the superior lip of spine of scapula. Then it is attached to the medial aspect of acromion process, and that is attached to the posterior aspect of the lateral one third of the scapula. So here in this picture from Grant's Atlas, you can see most of this. So here it is attached to this super knuckle line. Here it is attached to the external occipital protuberance. From here to here, so it is attached to the knuckle ligament. It is somewhat shown here. This, sorry, like this. This is the labeling, and you can follow it to this knuckle ligament. It's basically a ligament that is present like in this way. It is present between the concavity, posterior concavity of the cervical vertebra and the posterior midline, and it is attached to here this knuckle ligament, and then it is attached to all the thoracic vertebra down to 12 thoracic vertebra, and its insertion is on the root of the spinoscapula, superior border of the spinoscapula, the medial aspect of acromion, and the posterior aspect of the lateral clavicle. So if you try to understand it, its function will become very evident. We can divide the muscle into three parts: the fibers that are approaching from the superior aspect, the fibers that are approaching from the horizontal aspect, and the fibers that are approaching from the medial aspect, from the inferior aspect. So these horizontal fibers are majorly responsible for bringing the two scapula together. They are helping retraction of the scapula or adduction of the scapula. Then there are fibers, and be very aware that we are talking about this part of the muscle, the descending fibers, not the highlighted part. This is responsible for pulling the scapula upwards, so it is helping in elevation of the shoulder, shrugging of the shoulders. So even if you are sitting at rest, thus the maintained part of the scapula, it is due to these muscles. When you shrug the shoulders, it is due to trapezius, and even if a person is sitting still and they have one trapezius, one part that is affected, then that will be a drooped a little. So we talked about the horizontal fibers having adduction, that fibers from above descending part elevating it, and the fiber that is down at the ascending part depressing the scapula. But magic occurs when these parts work together. As you can very well see, the descending part are majorly attached to the lateral aspect of the spine or acromion process. So they pull up, and this part, the ascending part, they pull down here. So when mm, downwards pull is on the medial end and upwards pull is on the lateral end, this helps in the rotation of scapula. This helps in the rotation of scapula, and this rotation becomes very important when you are doing overhead abduction. So this is the one of the two muscles that is doing overhead abduction. The one that we saw earlier in this lecture was serratus anterior, and the second one is trapezius muscle. So here comes a question uh, regarding the injury of the trapezius muscle. It is, by the way, supplied by spinal accessory nerve. I did not show that. Let me show you that first before discussing the injuries. It is supplied by the spinal accessory nerve, and as you can see, I have discussed it in detail in my cranial nerves lecture. But you can see as it comes down from the skull, it supplies sternocleidomastoid and that supplies the trapezius muscle. So as you can see, it is coming down from the this area. So this is the posterior triangle of the neck. Again, The triangles are discussed in detail in head and neck lectures. So it is coming down from the skull all the way flying sternocleidomastoid and going to through the posterior triangle of neck to supply this trapezius muscle. So this is the trapezius muscle. So now the question that I was talking about, the question that bugs the students a lot is how to differentiate between the injury of the two muscles, both of those who are responsible for overhead abduction. You may be given an MCQ regarding a person is unable to comb her hair, a person is unable to reach the top shelf of her cupboard, but now which nerve is injured? Is there accessory nerve supplying trapezius is injured, or the long thoracic nerve supplying serratus anterior is injured? So the answer is to look for the cues in other functions or attachments or place of injuries. For example, if you are given a question scenario regarding the inability to overhead abduct along with winging of scapula, then this is serratus anterior. There is inability to overhead abduct along with the drooping of shoulders, then this is trapezius and long thoracic nerve. Sorry, and accessory nerve. Again, with the site of injury. If there is an inability to overhead abduct after a surgery of the neck, then we are talking about the injury of accessory nerve and posterior triangle. If there is inability to overhead abduct after radical mastectomy, where the breast tail was removed here, then there is an injury of long thoracic nerve. So that is how you can differentiate between the injury of long thoracic and accessory nerve. This brings us to the latissimus dorsi. So this is the large expanded muscles, the latissimus dorsi. It is the one that is arising from the back, and you can see this is the only muscle that arises from the pelvic girdle too, and it fans around the lower chest, comes around and gets inserted into the floor of the bicipital groove. Let us isolate its origin and insertion. Its origin from the lower aspect of abdomen is majorly through thoracolumbar fascia. I will show you again. And through thoracolumbar fascia on the iliac crest, and through thoracolumbar fascia on the thoracolumbar fascia to the lumbar vertebra, and directly attached to the lower thoracic vertebra. Then it has some slips that originate from the ribs also, lower few ribs, lower 5 or 6 ribs, and then goes up, may have some origin from this lower end of the scapula too, and it has insertion on this floor of the bicipital groove. So let me show you the muscle here again. So here it is through the thoracolumbar fascia, it is attached to the this area iliac crest. Through thoracolumbar fascia it is attached to lumbar vertebra. Directly it is attached to the lower 5 or 6 thoracic vertebra spine. Then the horizontal fibers go horizontally, may get attached here to the lower end of the scapula. Beneath it, they are attached to the lower few ribs, and as it goes, just like pec major, it winds around and turns around itself. Like, let me try to show you here. As you can see, the fibers go turn around the undersurface of this muscle teres major and gets attached to its lateral aspect and to the medial aspect of pec minor. So this is the attachment of latissimus dorsi. Due to its approach from the medial aspect, this muscle is a very powerful adductor of the shoulder joint. As you can see, it can pull the humerus along with the scapula. It acts as the adductor of the scapula as well as adductor of the shoulder joint. So in this particular aspect, you are only isolatedly shown the adduction of the scapula, and here you are shown the adduction of the glenohumeral joint. You can notice the movement of scapula beyond it too. So this muscle is very much important in pulling the arm from the abducted position in the adducted position, as it is occurring against the anteroposterior axis. So due to this very powerful movement, this muscle is also called climbing muscles of the body, because when you have head overhead abducted, you pull it down, you can bring the muscles here. When talking about the horizontal axis, as this muscle is lying on the posterior aspect of the horizontal axis, it pulls the humerus back, thus helping in extension. So it is lying back, so it is helping in extension of the shoulder joint. We talked about adduction, extension, and now there is medial rotation, as this muscle is getting inserted onto the anterior surface of humerus. When the anterior surface of humerus is pulled medially, it helps in medial or internal rotation of the humerus. So these are the functions of the latissimus dorsi. This muscle is responsible for extension, adduction, and medial rotation. That is why that helps in the climbing in the body. And also one more function that was not discussed, due to its sense of encompassing the body, this muscle when contracts, it pushes the ribs inwards, that helping in forceful expiration. So when you cuff, this muscle also helps in cuffing. It pulls the ribs downwards. And you may have experiences when you have prolonged periods of cough for a periods of few weeks or a few days. You may feel soreness in this part due to the latissimus dorsi. And counterintuitively, this muscle is responsible for forceful inspiration too. For example, when you have a fixed humerus, when you have put your arm here and when this muscle is contracted, do you remember the origin points were on the few ribs too? So the origins on the ribs are pulling against the fixed humerus, and they may help in elevating the lower ribs. So it may help in elevating the ribs too. So this is about it. And yes, I think I failed to mention the innervation. This muscle is supplied by thoracodorsal nerves that comes from the posterior cord of the brachial plexus. So as you can see, it is made by three divisions. This is the posterior cord and thoracodorsal nerve. Not going into its path right now, but it gets down and get inserted here, and its arterial supply is majorly through the lateral thoracic artery, or it has the branches here. As you can see, it has a supply from the branches that are supplying the posterior back, but thoracodorsal artery, that is one of the major supplies of the latissimus dorsi. Thoracodorsal artery, it's the branch of subcostal artery, sorry, the branch of subscapular artery, the third last branch of axillary artery. So it extends down to supply this, and this arterial pedicle is very important, because in sometimes reconstructive surgery, sometimes breast surgeries after mastectomy, this muscle is pulled up from its origin, and this supply is maintained, and this nerve supply is maintained, and this muscle is brought to the front of the chest to act as a prosthesis. Now this surgery is relatively less common due to the better prosthesis availability. So this is about it. So this is the latissimus dorsi. We talked about its injury, and yes, there are two triangles that are important here. One triangle is this one, that is the triangle of auscultation. It is created between the lateral border of trapezius, the upper border of latissimus dorsi, and this medial border of scapula. The lateral border of trapezius, upper border of latissimus dorsi, and medial border of scapula. This is the triangle of auscultation, because here the number of muscle layers and the scapula are away, so the chest wall is thin here, and you can better hear the sounds if you place your stethoscope at this point. And on the back, if you see here, you can see the lumbar triangle of Petit. So here on the back there is latissimus dorsi. Let me put it here again. On the back there is here latissimus dorsi and thoracolumbar fascia. On the front there is external oblique muscle, and below there is iliac crest. So this area, this is the lumbar triangle of Petit, and internal oblique muscle is making the floor of it. And this is clinically important, because this part present as a little weakness of the abdominal wall, and hernia may start from this point. So this is all about latissimus dorsi. Now we are going to discuss the three muscles that are on the back: levator scapulae, rhomboides minor, rhomboides major. I think these are simple enough. I won't be going into the models very much, but let me discuss it. Let's just talk about the levator scapulae. This muscle, it is proximally attached to, or its origin is from the transverse processes of C1, 2, 3, and 4 vertebra. The muscle fiber comes down from here and it is attached to the medial border of scapula above the spine of scapula. So this is the transverse process, C1 to C4, and it is attached here. So as the name indicates, this muscle helps in pulling the scapula upwards, so it is helping elevator of the scapula, and it is supplied by dorsal scapular nerve, and that's the nerve that comes from the brachial plexus and comes right down here beneath this muscle, running down, supplying all these muscles, and some direct branches from the cervical plexus. And there is a thing that I did not discuss with trapezius, but we'll discuss it here. If the scapula is fixed, it can help pull the neck laterally. So trapezius, similarly, when talking about the upper limb, would think about its functions as the mover of the upper limb. But if the limbs are fixed, then this muscle can help in laterally flexing the neck too. Next, rhomboides minor and major. Rhomboides minor arises from the lower cervical and upper thoracic vertebra C7 and T1, and from here it is attached to the medial border of scapula just against the root of the spine. So this is rhomboides minor, and then there is from T2 to T5. This is T2, and this is 3, 4, and 5. This is T5, and so below, and it is here inserted into the medial border of scapula on its posterior aspect from the root of the spine all the way to the lower angle. So this is the rhomboid major. So these are very flat muscles, and these muscles along with the levator scapulae are supplied by dorsal scapular nerve that comes from here and runs underneath these muscles right here. So this is supplied with a dorsal scapular nerve. So here is levator scapulae muscle followed by this rhomboides minor and this rhomboides minor and rhomboides major muscles. With rhomboides major and minor, major is responsible for this retraction of scapula shown right now, and levator scapulae helping along with trapezius upper fibers are descending fibers to help elevate the shoulders right here. And this was the nerve, the dorsal scapular nerve that I was talking about, coming from the brachial plexus and going down near the medial border of scapula right here, and underneath this rhomboides minor and rhomboides major. So this was about the nerve supply of these muscles, all three muscles. So here is a comprehensive picture of the muscles we have discussed. In the posterior aspect, we talked about this large muscle. This was trapezius, and we talked about its function of descending fibers, horizontal fiber. We talked about the retraction, rotation of scapula functions, its nerve supply, its blood supply, and we talked about how to differentiate its injury of spinal accessory nerve from that of long thoracic nerve. And along with that, there was a discussion of this triangle of auscultation. Then we discussed this large muscle. This was latissimus dorsi, its role in cuffing, its role in climbing, its function of adduction, extension, and medial rotation. And we talked about then of these three muscles: this levator scapulae, elevating the scapula, and this rhomboides minor, and this rhomboides major, bringing the scapula near the middle hand, and the nerve supply. So here is a picture from the Keith Moore's clinical anatomy. You can pause this video here and go through the movements of the scapula we have gone through far. Which muscles are producing elevation of the scapula, marked as 1, 2, and 3. That will include trapezius, descending part, levator scapulae, and rhomboids muscle. So you can go all the way down this table. You can take a screenshot of this picture from Keith Moore's anatomy and revise the different movements of scapula that were provided. So that brings us to the end of the pectoral axio-appendicular muscles. Now we will start our discussion regarding the scapulohumeral muscles, the intrinsic muscles of the upper limb. We will be discussing the deltoid, the four rotator cuff muscles that are the supraspinatus, infraspinatus, teres minor, and subscapularis, and teres major muscles. Although technically biceps and triceps can be considered scapulohumeral muscles because of their attachment of long heads to scapula, but we will leave that discussion with the arm along with the coracobrachialis muscle. So here is a picture for a screenshot if you want from the Keith Elmore's anatomy regarding origin and insertion. Let's dive into them one by one. The deltoid muscle. So deltoid was the large muscle that is forming the contour of your shoulder joint, all this part. So this is the deltoid muscle, and it has the anterior parts, it has the acromion part, and it has the posterior part. You can see well here. Let us break it down its origin and insertion. The origin, it's from above. It's from the anterior aspect of lateral one third of the clavicle. It is from the outer aspect of the acromion, and it is on the inferior lip of the spine of scapula. So this part will give rise to the anterior fibers, this will give rise to the acromial part, and this will give rise to the posterior aspect. So this is the origin part, and it gets inserted down here in the deltoid tuberosity on the lateral aspect of the shaft of the humerus. We can get a little more technical regarding its pinnate nature, and the deltoid muscles, as its anterior fibers and posterior fibers have a little slightly different functions as compared to the acromial fibers. So the acromial fibers are needed more powerfully, so these are pinnate. So let me, okay, so the muscles are arising from four tendinous arches, and here it's inserted into these three tendinous arches. And let me get this more clear. So it is arising inserted into this pinnate aspect, and you will be seeing some pictures like this too in your textbooks. So these pinnate fibers, they interlace with one another like this, and like this, and that provide less range of motion, and the trade-off is it gives more power in them. So this is the origin and insertion, and let us talk about its functions. The acromion part is majorly responsible for abduction of the shoulder joint, the glenohumeral joint, and technically speaking, glenohumeral joint, the abduction is from the 15 to 90 degree. This is more abduction shown here. As you can see, as the abduction goes beyond 90 degree, it is made possible due to the rotation of the scapula. That is not the function of the deltoid. The deltoid's function is to abduct from 0 to 90 degree, from somewhere here to here. So this is the function of deltoid majorly. The function from 0 to 15 degree, as you can see, the deltoid is not highlighted. 0 to 15 degree, this is due to the supraspinatus, as we will see shortly. From 20 to 90 degree, this is majorly through deltoid, and the rest of the movement is due to this rotation of the scapula brought about by the trapezius and serratus anterior. To be more accurate, 15 to 90 degrees is not very much accurate, because it's not like the shoulder goes from 15 to 90 degree and then scapula starts rotating. The scapula is rotating throughout along with it. So for every 1 degree of for every 2 degree of glenohumeral, there is 1 degree of scapular rotation. So that is made possible due to it. Then there are the anterior fibers. The anterior fibers are flexor, adductor, and medial rotator. So they provide flexion, bringing the humerus to the anterior aspect along with the pec major. As you can see, this function is made possible because these fibers are approaching the horizontal axis of the shoulder joint from anterior aspect. Let me show you again. So this is the flexion function. Then the fibers are approaching from the medial aspect, so these are helping in adduction. As you can see, from abducted position it is brought to adduction, and now this movement is produced by the this. And last but not the least, medial rotation. As it is from the medial aspect, it is pulling the anterior surface of the humerus or medially, or it is technically it's pulling lateral aspect to forward direction. So it is pulling the lateral surface forward direction, so it is helping in adduction. So it helps in flexion, adduction, and medial rotation. With this, we move on to the posterior fibers of the deltoid. These are arising from the spine of the scapula. These will help in exactly opposite functions in the lateral rotation, extension, and abduction. Extension, lateral rotation. Let me show you. Here the lateral aspect is pulled backwards, so there is lateral rotation. You can see the palm of the hand is going to face outward direction. So this is lateral rotation. And as this muscle is approaching the horizontal axis from the posterior aspect, you can see right here, it is helpful in pulling the arm from in extension, pulling the arm to extended position from the flexion, and then also in hyperextension as shown right here. So, and these are the functions of the lateral head of the triceps. So we talked about the not triceps, the posterior aspect of the deltoid. We talked about the deltoid, its origin, its three parts, and the origin of the parts, multi-pinnate nature of the acromion part, and the functions of the three parts. And this anterior part was responsible for flexion, medial rotation, adduction, and this part was responsible for abduction from 15 to 19 degree, and this part was responsible for extension and lateral rotation. And the nerve supply is very important for this nerve. This nerve is muscle is supplied by axillary nerve. So axillary nerve, let me go back, let me highlight the muscle here, and yes, so this is the axillary nerve. As you can very well see, this axillary nerve winds around the head of the neck of the scap of the humerus bone before reaching the undersurface of the humerus, and as it does so, it is vulnerable at this point, because if you inject a person with intramuscular injection and the needle is misplaced and goes down the way all the way to the nerve, then this nerve can be damaged even improperly placed injection when it is placed here. Alternatively, when this neck of the humerus is fractured due to some injury, then this nerve can be damaged. Or is if a person having abducted shoulder leads to dislocation of the shoulder, this nerve can be injured. So in all of these cases, this nerve can be injured, leading to the paralysis of the deltoid muscle, leading to weakness of abduction and also the cutaneous play over the aspect of the skin over the deltoid. So this is all about the deltoid muscle, its attachments, origin, insertion, nerve, and its functions. This is the muscle that whose function will be lost along with teres minor, and this is the area of skin whose function will be lost. This proximal aspect of shaft of humerus, this can be damaged too. Then there are rotator cuff muscles, subscapularis, supraspinatus, infraspinatus, and teres minor. Subscapularis is muscle that arises from the subscapular fossa on the anterior aspect of the bone. It arises from here and it goes on and inserts on the anterior aspect of the lesser tubercle. So it attaches here and it is supplied by upper and lower subscapular nerve, and this muscle pulls the anterior surface of humerus towards itself, so it is helping in medial rotation. Here is the origin and insertion of the subscapulary muscle with its function of medially rotating the shoulder joint, glenohumeral joint. And the nerve supply is through the posterior cord of brachial plexus, where it is supplied by the upper and lower subscapular nerves. That also the lower subscapular nerves goes on to supply teres major right here, as it can be seen going beyond the muscle. It is supplied by the arteries that are present on the scapula, and we will go into the different branches of axillary artery. We'll discuss in the axilla part. Then there is on the back we can see supraspinatus, infraspinatus, and teres minor. Let's start with supraspinatus, originating from the supraspinous fossa, inserting into the superior aspect of the greater tubercle. As you can see, when this upper part is pulled inwards along the anteroposterior axis, the arm will go outwards. This will help in abduction of the shoulder joint. Here is the origin from the supraspinous fossa, inserting into the upper part of greater tubercle, and this muscle being primarily active in the abduction during the first 15 degrees. So this part basically from here to here, this is majorly through the supraspinatus part from here to here. So this is the supraspinatus, although it remains active the rest of the part too, but especially from the first 15 degrees, this is due to the supraspinatus muscle. This muscle, along with the infraspinatus and teres minor, is supplied by this suprascapular nerve coming through this suprascapular notch. It supplies supraspinatus, goes through a spinoglenoid notch, and goes to the infraspinous fossa too. So this was regarding the supraspinatus muscle, and then there is infraspinatus muscle arising from the infraspinous fossa, getting inserted into the middle tubercle of the greater middle facet of the greater tubercle, and as you can see, it is approaching the humerus from the posterior aspect. When it pulls, it helps in lateral rotation of the scapula. Here are the origin and insertions of this muscle. The function of the muscle as being the lateral rotator of the humerus at shoulder joint, and the nerve supply as the suprascapular nerve comes through the suprascapular notch, passing between the spinoglenoid notch, going to the spinous fossa to supply this muscle. That brings us to the last of the rotator cuff muscle, that is the teres minor. It is rising from here, the upper aspect of the lateral border of scapula, and from here it is inserted into this lower facet of the greater tubercle on the posterior aspect, and this is the muscle that runs between these two parts, and as you can see, it will have function similar to those of infraspinous, that is the lateral rotator of the shoulder joint. Here is the origin and insertion of the muscle, along with the function as lateral rotator of the shoulder joint, like this. And the nerve supply of this muscle is through the axillary nerve, as it goes and winds around the humerus before supplying deltoid. It gives us a branch that goes to the teres minor muscle. So this is the axillary nerve going around the neck of the humerus, and this the further part going to the deltoid is cut right now. So this is its nerve supply. So these are all the muscles of the rotator cuff, and together these muscles are protecting the shoulder joint from all the aspects. On the anterior aspect, there is subscapularis muscle. On the superior aspect, supraspinatus, and posterior aspect, there is teres minor and as infraspinatus and teres minor muscles. So it is protecting from above, back, and forward, above, and back. And in addition to having their isolated functions, those were medial rotator for subscapularis, abductor for supraspinatus, and lateral rotator for infraspinatus and teres minor. These are the muscles that helps majorly, they help in fixating or stabilizing the glenoid head in the shoulder head in the glenoid cavity. That brings us to the last of the muscle that we're going to discuss today, that is the teres major muscle. This muscle arises from the lower part of the lateral border of the scapula on the dorsal aspect and goes on to get inserted into the medial lip of the bicipital groove as shown right here. From the lateral lip, I would like to remind you, was pec major. On the bicipital groove floor, there was latissimus dorsi. On lateral lip, on medial lip, there was teres major. So here is the muscle with its origin and insertion. Along the horizontal axis, this will help in extension. As you can see, it is approaching the shoulder joint from back. So as it comes down, like now, it will help in extension, pulling it back. So this will be its function. From here, pulling it back. So this will be its function. From here, pulling it back, because it is approaching from the posterior to the horizontal axis. It will help as adductor, as the arm is in abducted position. Here you can see pulling it arm to the by the side. This will be made possible by a teres major along with other muscles like pec major, latissimus we talked about. So it pulls the arm to closer here. And last but not the least, this will be medial rotator, as it is attaching on the anterior surface and pulling the anterior surface medially. So as the anterior surface is pulled medially, this will lead to the medial rotation of humerus. So this brings us to the end of the muscles, and with this we will close our discussion regarding the muscle, and we will before finalizing the lecture, I would like to go into this topic, intramuscular spaces. All of these muscles that we discussed till now, excluding biceps and tricep, the particular arrangement of these muscles leaves some gaps between them. So these are the few spaces that are created between them. So here, this is the quadrangular space, and it is created by subscapularis in front and above, and behind it above there is teres minor too. On the lateral aspect there is humerus. On the medial aspect there is long head of triceps. On the inferior aspect there is upper border of teres major. So this is the quadrangular space. It contains axillary nerve and posterior circumflex branch of posterior circumflex humeral artery and vein. I will show you in the model too. Then there is this space, upper triangular space. It is created by superiorly through the subscapularis and teres minor, inferiorly by teres major, and medially by long head of triceps. It contains circumflex scapular artery. Then there is this, there is inferior triangular space. It is created by teres major above, shaft of humerus laterally, and this long head of triceps medially, and from that the structure is going to the posterior compartment of arm, that is the radial nerve and profunda brachii vessels. Those are passing through. So these are the structures that are visible right here too. And let me go through the 3D model. So between this whole area, this is the quadrangular space, and it is present beneath the scapula. I've added the subscapular muscle here. So anteriorly subscapular muscle, posteriorly teres minor. So don't be confused, because in different books you will see teres minor or subscapular is alternatively mentioned as the superior border, teres major as inferior border, this triceps as lateral border, and this humerus as the triceps as medial border and humerus as the lateral border. And passing through them are this artery, that is the posterior circumflex humeral artery, and this nerve, that is the axillary nerve, that is going to supply the deltoid and the skin over the deltoid, and teres minor muscle too. Now there is this triangular space, this small one, this area uh, covered by long head of triceps laterally, subscapularis or teres minor superiorly, and teres major inferiorly. And here is the axillary artery, its branch, subscapular artery, its branch, circumflex scapular artery. So this is the only structure that passes through its circumflex branch of scapular artery on the way to go to the infra spinous fossa. And last but not the least, this triangular space, this is the lower triangular space covered by teres major and latissimus dorsi, to be more honest, above, and humerus on the lateral aspect, and triceps long head on the medial aspect. And from them there is these arteries and veins going to the back of the arm. That is the radial nerve, and this is the profunda brachii artery on the way to the back of the arm. So these are the structures that were making the spaces. These are the pictures from Natter to go through. If you want to, I think we have discussed the clinicals along it, and these may be important. These may become important when these structures are damaged. For example, this quadrangular space is at the risk of injury when there is a fracture of the neck of surgical neck of humerus, or when then there is downward dislocation of the shoulder joint. So axillary nerve and posterior circumflex humeral arteries may be damaged. And in Saturday night palsy, we will discuss in the brachial plexus, the lower triangular space, the radial nerve and profunda brachii may be compromised. Quiz, very simple quiz. Just pause the video here and try to figure out these muscles. These are pictures from Gray's Anatomy flashcards. Pause the video at different parts and try to figure out all of these muscles. I think apart from bicep, tricep and coracobrachialis, I have discussed all of the other muscles in quite extensive detail. Thank you so much for listening. I hope so this had been helpful for you. If you have any questions or feedback or suggestions regarding this lecture, please mention down in the comment, and you may reach us through our website. By the way, all the recordings with presentation material is present there, and our Facebook and YouTube channel. Please feel free to reach out. If you have any queries and suggestions, please let me know. I will be trying to follow up with further lectures on the upper limb. Thank you so much.